Good evening to everyone present here with us today. This is Shreyan from IGCP, today's moderator. I would like to welcome all the viewers who have joined our platform for better exchange of knowledge that is going to be shared by our keynote speaker, Doctor, for today's session.
Good evening
With
to everyone
much
present here
pleasure
with
and
us
honor,
today.
I would
This
like
is
to
Shreyan from
welcome a very
IGCP,
renowned
today's
doctor,
moderator.
Dr.
I
Rajiv
would like to
Chawla.
welcome all the
Sir
viewers who
is
have joined our
MBBS,
platform for
MD,
better
F
exchange of knowledge
Diabetes,
that is going to be shared by our keynote speaker,
FRSSDI,
Doctor, for today's
FACP,
session. Good evening to
FRCP,
everyone present here with us
FACE,
today. I would like
Director
to
and
welcome
Senior
a very
Consultant
renowned doctor, Dr.
Diabetologist
Raj. I
at
would like
North
to
Delhi
welcome all the
Diabetes
viewers
Center.
who have joined our
Sir
platform
is
for
a
better
professor
exchange
at
of knowledge that
Jaipur
is going to be
National
shared by our
University.
SDI,
With the
Dr.
help of Sir and
FACP.
his wonderful
Good
insight, we
evening to
will be
everyone
taking a
present here
close
with us
look on
today.
today's
I would
topic,
like to welcome
which
a
is the
very
role
renowned
of
doctor,
peripheral
Dr. Raj at
neuropathy
North
in
Delhi
diabetes
Diabetes Center.
diagnostic
Sir
roadmap.
is a
Now,
professor at
without any
Jaipur
further delay, I
National
would like to
University.
welcome Sir at our
With the
forum
help
and
of
would
Sir
like to hand
and
over
his
the session
wonderful
to him.
insight, we will
Over to
be
you,
able to
sir.
let everyone know today's
Yeah, you have to mute yourself because a lot of echo effect is coming. Thanks a lot for this wonderful introduction. And tasks assigned to me today is to how to diagnose peripheral neuropathy in a diabetes clinic or in a diabetes center. And I'll keep it very, very simple for all those physicians and clinicians that if they just spend 2 to 3 minutes in their clinic on the foot, they'll be able to reach to the diagnosis of peripheral neuropathy in a patient with type 2 diabetes. I hope I am audible and everyone can see the slides.
Yes, sir. You're
Okay.
perfectly audible.
Done. So, diabetic neuropathy is defined as a demonstrable disorder which is diagnosed either clinically or subclinical that occurs in the setting of type 2 diabetes or type 1 diabetes without other causes for peripheral neuropathy. That means most of the time this is a diagnosis by exclusion, someone who is already suffering from type 1 or type 2 diabetes. And if we can exclude other causes like B12 deficiency, many a times they are alcoholic, so alcoholic neuropathy or autonomic neuropathy or other causes of neuropathy, many times it is toxicity of various heavy metals which lead on to neuropathy, and many times patients have been on certain drugs which can lead on to neuropathy. So we have to rule out all other causes to label it as diabetic neuropathy. It includes manifestations in the somatic and or autonomic parts of peripheral nervous system. This is one of the simplest definition of diabetic neuropathy, which came as early as 1988, and it was defined in San Antonio Consensus Conference that this is how a diabetic neuropathy should be defined. There have been various estimates on prevalence of diabetic neuropathy. This is one of the, again, earliest study done in 1993 by a very close friend, Professor Jargar from Sher Kashmir Institute, and he's a very senior endocrinologist. And he said that diabetic peripheral neuropathy, there have been various estimates. It could be seen in about 62% of patients once it is based on subjective complaints of the patient. If you try to document the signs, again, almost 55% patient might have evidence of peripheral neuropathy. But if you perform a nerve conduction velocity in a patient who has type 2 diabetes or type 1 diabetes, then it is possible that 100% of those patients, by the time they have diagnosis of diabetes for close to 10 years, they have established neuropathy. That means it is very, very common. And you could see that as the years of diagnosis, so since the years of diagnosis, as the years are increasing close to 10 years, most of the patient, they have some evidence of neuropathy. So again, in this diagram or in this slide, you could see that if you are going to go only by the symptom, maybe that may be the tip of the iceberg. If you perform a clinical examination on that or try to quantify that, you may pick up that 50% patient might have peripheral neuropathy. But if you perform electrophysiological testing or nerve conduction velocities, then almost 100% patient will have evidence of diabetic neuropathy by the time they have diagnosis of diabetes for close to 10 years. As I said, various studies have given various percentage of prevalence of neuropathy, but this is one of the earliest study, a very, very benchmark study, Rochester Diabetic Neuropathy study, which said that if you sum up all sorts of neuropathy in the setting of type 2 diabetes, almost 60% patient will have evidence of diabetic neuropathy. If you're talking of only distal polyneuropathy, again close to 50% patient will have neuropathy. If you take into account the carpal tunnel syndrome, that may be seen in 30% of the patient, and alone autonomic neuropathy could be seen again in 5% of the patient. So if you sum up most of these patients, you will realize that they have evidence of neuropathy. When we talk about pathogenesis of diabetic neuropathy, per se, it is hyperglycemia in the setting of diabetes, which through various routes, because if you have persistent hyperglycemia, it is not only going to induce oxidative stress, there are going to be higher glycated products, and through diacylglycerol protein kinase activation or through polyol pathway, through persistent hyperglycemia, it leads on to sodium potassium ATP pump stimulation. There is a usage of this pump, so there is a vasoconstriction, which then leads on to endoneural neural hypoxia. So nerve conduction velocities get impaired. That is what I said. If you perform nerve conduction velocities, you will find that anyone who has diabetes for 8 to 10 years, most of them they have some degree of neuropathy, which is already there, and this subsequently leads on to degradation of axonal structure, which can be picked up if you do in an examination of tissues from patient with diabetes. That means if you are performing a nerve biopsy, you'll find that there is a occlusion of vasa nervorum, which is found in most of the patient with diabetes, because there is an evidence of damage to the nerve which can be picked up by nerve biopsy. So it is said that if you perform a sural nerve biopsy, probably most of the patient, almost 100% patient will have some degree of diabetic peripheral neuropathy if they have persistent hyperglycemia close to 8 to 10 years. Not only that, neuropathy is very, very common even before the onset of disease. That means once you are at a stage of, you may say, IGT or pre-diabetes. So again, it has been seen that many patients who have uh, pre-diabetes, maybe their fasting is high or postprandial is high, they are yet to get the diagnosis of type 2 diabetes. And if you do a examination in them, again, they also might have an evidence of neuropathy. That means probably neuropathy comes much earlier than expected. Many times, even at the stage of pre-diabetes also, this could be established. Why it is so? The metabolic theory of diabetic neuropathy says that there is an insulin independent glucose uptake. So, even if you have a type 1 diabetes patient who has total insulopenia, or type 2 diabetes patient where there is a insulin resistance and a relative insulin deficiency, so there is going to be a direct uptake of glucose which is independent of insulin levels or availability of insulin into the kidneys, into the retina, and into the nervous tissue. So that is why microangiopathy, whether you talk about presence of microalbuminuria or presence of retinopathy or neuropathy, these complications set in much earlier in the course of the disease, because all these capillaries, they tend to have a direct glucose entry without insulin requirement. So persistent hyperglycemia will do lot of damage to microcapillaries. That is why neuropathy and retinopathy and even diabetic nephropathy in the form of microalbuminuria comes much earlier than expected. This is one of the benchmark studies or a landmark study by Dr. Ramachandran from Chennai on 3,000 patients with an average age of 52 years. And again, in his 3,000 patients, he has seen that retinopathy was seen in 23% of patients, nephropathy was seen in 5.5%, neuropathy that time in his study was seen in 27% of patients. But when you talk about macrovascular complication, coronary artery disease was seen in 11% patient. PVD, fortunately, in Indian patient is lesser as compared to Western or Caucasian patient, was seen in 4% of patient. Hypertension was there in 38% of patient. This is almost 30 years old study. We also did a similar study at our center in 2004, and this I presented at No Nordis Diabetes Uptake in 2004, and we were given the Best Paper Award on this study. We picked up 720 type 2 diabetes patients and we found that retinopathy was seen in 21% of patients. Microalbuminuria was seen in 41% of patients. Neuropathy in our study was seen in 15%, and it is a known fact that peripheral neuropathy is more common in southern patient as compared to North Indian patient. CAD was in 7% and PVD was almost alike what you have seen in Dr. Ramachandran's study where it was close to 4%. So let's see how we can classify diabetic neuropathies. These could be symmetrical neuropathies, where distal sensory or sensory motor peripheral neuropathy is one of the commonest form of neuropathy. It could be a small fiber or a large fiber neuropathy. It could be an autonomic neuropathy, or there could be an asymmetrical presentation of neuropathy in the form of involvement of the cranial nerves or truncal involvement in the form of thoracic radiculopathy or a limb mononeuropathy, which could involve single or multiple nerves, or entrapment neuropathy or lumbosacral radiculoplexopathy. But combinations of these neuropathy like polyradiculoneuropathy or diabetic neuropathy cachexia are also very common in diabetic patients. So let's see how there is a presentation of small fiber neuropathy. It is primarily symptoms predominant form of neuropathy. Pain is of C fiber type. There is a burning and superficial pain with allodynia, but subsequently these patients they tend to develop hypoalgesia. That means even that burning and pain disappears. They have a defective warm thermal sensation. That is how it can be picked up by a thermal pen or a hot water filled in a cup of water, warm water, whether patient can feel it or no. A defective autonomic function could be seen in these patients. They have a dry skin and cold foot, and there is a decreased sweating as compared to the large fiber neuropathy. Their symptoms are different. I'll be alluding to that. Reflexes, motor are classically normal in the beginning. Electrophysiologically also in the beginning it can be silent, but it can be picked up clinically. That is why I have kept the topic how to do a physical examination on a bedside in a center to pick up various forms of neuropathy. So you may use a 10-gram monofilament or a pricking sensation which can be felt from Wardenberg wheel, which can be run over the shin bone, over the leg, or a warm thermal perception either through a warm water or a thermal pen is available, which can be just put in hot water and then you can apply that tip on the feet or on the legs or on the ankle to see whether patient can feel that warm sensation or no. And these patients are at a greater risk for ulceration and gangrene once they have a small fiber established neuropathy. Compared to that, large fiber neuropathy, there have these patients they have impaired vibration perception and position sense. They have diminished tendon reflexes, which are otherwise normal in a small fiber neuropathy. Pain here is not C type, it is delta type, deep seated pain. That means something like toothache that you are not able to identify which tooth is actually paining. So it is more like a cramp like pain into the feet and into the calf muscles. There could be sensiatexia, there could be wasting of small muscles of hand and feet with weakness, with hematoes typically seen. There could be shortening of Achilles tendon, and these patients they have a hot foot as compared to small fiber where it is a cold foot with absence of sweating. And these patients are at a greater risk for Charcot's neuroarthropathy, while small fiber patients are at a greater risk for developing amputation and gangrene. So let's see how do we do an examination on feet assessment of for assessment of significant neuropathy. It is five simple clinical tests which can take you to the diagnosis. Earlier, I said that you do a sural nerve biopsy or a nerve conduction velocities. All those things in a clinic are never required. We hardly get any nerve conduction velocity to establish the diagnosis, and we make a clinical diagnosis by using a 10-gram monofilament, using a pinprick, a 120 hertz tuning fork, establishing a ankle reflex or looking for an ankle reflex, and if required you can quantify that with a biothiometry. So I'll show you how to use these 10-gram monofilament. You put it on 5 points on the foot and look for whether patient can feel it or no. You don't have to put it very deeply. You just put 10-gram pressure so that it just buckles. So you can use this for diagnosis of peripheral neuropathy along with 120 hertz tuning fork to look for vibration sense. Pinprick also you can be, but mind it, don't prick it very deep because many time patient may not have sensation and you may do an injury to the foot. So you may look for ankle reflex through a hammer, or if you want to quantify, you may do a biocheziometry. So whenever we are suspecting diabetic neuropathy, we need to do a bedside score. This is our own score, which we have used over last 20 years in various studies, and it is now totally validated. It was suggested earlier days, 30 years ago, by Young et al. Criteria. It was taken as a Young et al. Criteria that you can do NSS and NDS, but I suggest that if you do both the scores together and try to sum them up, that can take you to the diagnosis of peripheral neuropathy. NSS is when you are looking for symptoms of neuropathy. NDS means when you are looking for disability score, that means you are trying to establish if there are certain signs of large fiber and small fiber, and you can do a quantification also. This is what is neuropathy symptom score. Symptom score means if patient says that I have burning, numbness, or tingling into my feet, then you score it. If all three symptoms are there, it is score stateway 2. If there are no symptom, it is a 0 score. Patient says that I have fatigue, cramping, or aching in my calf muscles, more so in the night, then the score is stateway 2 plus 2. That means if patient has all these symptoms, score is stateway 2, 2, 2 plus 2. That means it is exactly 6. Now, if patient has symptoms, look for disability, that is neuropathy disability score. Try to do a ankle reflex. If it is normal, it is 0 score. If you cannot see a proper ankle reflex even on reinforcement, then it is a straightway score of 2. You may do a vibration sense only through tunic fork. If it is absent, it is 1. Pinprick sensation, if it is absent, it is 1. If patient cannot feel a thermal pen or a little lukewarm water filled in glass of water or in a cup, then obviously score is already 1. That means if you sum it up, the score comes out to be 5. So if you take together NSS along with NDS and score comes out to be more than 10 to 12, it takes you to a clinical diagnosis of peripheral neuropathy. And it is validated today that if you do an NSS NDS score, even in our RSSDA guidelines, when we talk of not doing too many investigation in limited care as well as in standard care, we have put this reference based on our studies that if you do a NSS NDS score, straightway you can make the diagnosis of peripheral neuropathy on the bedside. It takes less than 3 minutes, I can tell you. So this is one of the earliest study which I told you, which we presented at non-Nordic diabetes update at Singapore. We looked into the prevalence of diabetic peripheral neuropathy by first doing NSS NDS score and then trying to quantify through biothesiophy. And we also look for co-association of peripheral neuropathy with other complication. This is what is biothesiophy, which is available in the market. It costs less than 50,000 today. Most of the clinics can do. Basic idea is that with this you can actually quantify the amount of sensory loss by this button, which can be rotated like any dial. And here you can see a needle which keeps moving. As you increase the voltage, it starts going from 0 to 10, 20, 30. So all those patients who cannot feel a sensation at 10 volts of current, that means they have peripheral neuropathy. So biothesiophy in clinic can be an ideal diagnostic tool for quantification. You can repeat it after 1 year, so it gives you the prognosis whether patient has done well or patient has deteriorated. And in future follow-up also it helps based on your yearly evaluation. So from our study we concluded that if you do a NSS NDS score and then try to quantify with a vibration perception threshold meter or biothesiophy, it can take you to the diagnosis of peripheral neuropathy. But what was much more important almost 20 years ago, which gave us an insight that if you have these symptoms and you can quantify and can make a diagnosis of peripheral neuropathy based on NSS and NDS. It can has it can have long-term implication, because if you have peripheral neuropathy, chances of having retinopathy are very, very high. It is 67% versus those who had normal NSS, NDS in 21%. Chance of getting microalbuminuria is much higher if you can have a positive NSS NDS score. So based on our own studies over 10 years, we did the validation of this score, and this we presented at IDF 2015, and subsequently we got it published also. So based on our own data, we said it is only a 2-minute foot examination which is required, which can take you to the diagnosis of peripheral neuropathy. Try to examine both surfaces of the foot. Ask patient to remove shoes as well as socks. Examine the nails. Look for any foot deformity if it is there. If there is any callus, or if there is any foot deformity or Charcot's neuropathy, or there are cold extremities, you can feel for pulsation, dorsalis pedis, and posterior tibial, and also try to examine the shoes, because many times the patient has neuropathy and patient is wearing tight shoes or narrow toe, then they are likely to hit that themselves, and they are likely to develop neuroischemic ulcers. This is how you use monofilament. I told you, demonstrate sensation on the forearm or hand first as a demonstration. Once they are able to feel it on the forearm or hand, then you put monofilament on 4 points on each foot. That means 8 points on both the feet. And if all 8 points are having absent sensation, chances are that this can predict severe neuropathy, and these patients are likely to have foot ulcers subsequently. The risk of developing or prediction for developing foot ulcer is as high as 95%. This is how you apply monofilament on 4 points, which I have given you: on big toe, then first metatarsal head, third and fifth metatarsal head. Many times we also use a insole here, which can be used here also. So even you can do examination at 5 points. You should put enough pressure so that it just buckles the way I have shown you in this picture. So in our study, we found, I told you, the peripheral neuropathy was seen in 15% patient, and most of these patients, they had sensation with more than 25 volts, which can be felt. And we try to correlate it with microalbuminuria and retinopathy. I have already told you. And we said that based on our study, the sensitivity of picking up peripheral neuropathy was as high as 71%. Specificity was 90%. It had a positive predictive value, 57%, and a negative predictive value. That means if this is normal, you can almost predict that patient has no peripheral neuropathy. From our studies, we said that neurological examination like NSS and NDS can be an important bedside tool in the clinics for early diagnosis of peripheral neuropathy with a sensitivity of 70% and specificity as high as 90%. It is a very simple test. You don't have to use any gadgets at all. Four things in your hand, just apply it on the foot, each foot, 2 minutes examination. It is simple, acceptable, reproducible, and validated as per our study. So that is how, if you do a bedside examination of peripheral neuropathy, not going into detailed investigation like nerve conduction velocity or EMG or sural nerve biopsy, it can take you to the diagnosis of peripheral neuropathy, and it takes less than 2 minutes. And most of these slides and studies are published in my own book, that is Complication of Diabetes and Manual of Diabetes Care, which are available with the JP publisher. Any young diabetologist or physician, those are keen. These are very, very simple handbooks for usage, and they can be much wiser in their clinical practice. Thanks a lot. If you have any questions, I'll stop sharing here my presentation. And if you have any questions, I'll be more than happy to answer that.
Thank you, sir, for this wonderful presentation. We do have some question if you'd like to take that up. So, sir, the first question is, what are the earliest clinical and subclinical indicators of peripheral nephropathy in diabetic patients? Sorry,
Neuropathy.
neuropathy in diabetic patient, and how can they be effectively identified?
This is what I said, that if patient says that I have aching, paining, cramp-like pain, tingling, paresthesias, allodynia, or feeling of numbness, that means patient has neuropathy. So I subsequently told you if patient has any of these symptoms, these are neuropathy symptom score, then we must do a examination on the foot that so as to establish whether patient has only NSS or disability score also positive. Disability I have told you can be picked up by a monofilament, by a thermal pen, by a pinprick, and by using a hammer establishing an ankle reflex. So if you have both NSS and NDS and sum it up together, you can reach to the diagnosis of peripheral neuropathy without doing any sophisticated examinations or investigation at all. And it is a validated score even if you put up a diagnosis of peripheral neuropathy by this 2 minute bedside examination in your clinic, you are good enough to diagnose peripheral neuropathy and you can put it in the label of diagnosis.
So the next question is, what diagnostic tools or methodologies have proven most effective in differentiating between diabetic peripheral neuropathy and other neuropathies?
See, we are not talking of blood investigation. Many of time patients with type 2 diabetes or type 1 diabetes, those who are long standing, they are on metformin, especially type 2 diabetes patient, they might have B12 deficiency, which can lead on to peripheral neuropathy. Many patients take alternative medicines which have lot of heavy metals like lead and cadmium and other things that can also lead on to peripheral neuropathy. Many patients might have habit of taking lot of alcohol even if it is not diabetic neuropathy, it may be a alcoholic neuropathy. So similarly, there may be many reasons for having peripheral neuropathy. So we have to exclude those causes because for every patient we cannot get all those tests done. We are not talking of sural nerve biopsy to establish the diagnosis. We are not talking of nerve conduction velocity. When we are talking of a clinical diagnosis of peripheral neuropathy, you just rule out other causes of neuropathy by history examination, history, and then do NSS NDS score on physical examination, and you can reach to a diagnosis of peripheral neuropathy.
Thank you. So there's one last question. What role does patient education and self-monitoring play in the early detection and management of peripheral neuropathy in diabetes?
First thing, second, third slide, I said how neuropathy starts. There is a persistent hyperglycemia, which through various pathways, either polyol pathway or advanced glycation pathway or PKCB pathway, that leads on to damage to capillaries. There is a direct infiltration of glucose into the capillaries because of persistent hyperglycemia, and that leads on to axonal nerve damage or demyelination. So best thing is to have a very good glycemic control. If patient has hypertension, that also should be under good control. If patient has B12 deficiency, that also should be supplemented, especially those patients who are on high doses of metformin, they might have B12 deficiency. So we may supplement B12 after checking their blood levels. So once we have ensured a good glycemic control, a blood pressure control, and most important thing is again stopping smoking and alcohol because both these things, even smoking can worsen neuropathy, and I told you large bouts of alcohol can worsen neuropathy. So cessation of smoking, cessation of alcohol habit, ensuring a good glycemic control, a good blood pressure control, and if required, a supplementation of B12 can help most of the patient in getting neuropathy controlled. But many patients, those who have too many symptoms, positive symptoms like burning, severe distress into their legs and cramping and pain, and something as if their feet are burning, they can improve with usage of pregabalin and gabapentin. Both these drugs are US FDA approved, and now even local creams are available of pregabalin and gabapentin, which can be applied on the feet or on the soles, which can reduce the symptoms. But most important thing, which goes a long way in reducing the progression of neuropathy, is glycemic control, blood pressure control, stopping alcohol and smoking, and if required, a B12 supplementation along with pregabalin, gabapentin, or tricyclic antidepressants like nortriptyline. These drugs are very, very useful.
Thank you so much, sir, for answering all our questions. That's all from our audience. So,
Thank
sir,
you.
before concluding, any take-home message from your end?
I think last word what I said, it is tight glycemic control along with blood pressure control, and stopping alcohol and smoking goes a long way in preventing or in checking the progression of peripheral neuropathy. So, and we must be very, very alert in picking up those symptoms and establishing a diagnosis, which takes only 2 minutes in your clinic. You may not go for very sophisticated tests. Just use NSS NDS score and it can take you to the diagnosis of peripheral neuropathy.
Thank you so much, sir, for
Thank you.
joining us today, sir. With your
Thanks a lot.
permission, I would like to conclude
Thank
today's
you.
session.
Good night, everyone, and stay safe. Bye.
Right, sir.
Bye.